Good morning. My name is John Martin, and I work in utilization management on the mental health and substance abuse side. So again, as was said earlier, I'll be available, as will some of my teammates, to answer any questions you might have. Hopefully we can manage that. Today, let me get the right slide here. I want to briefly talk about service authorization request basics, and we'll kind of take some broad strokes here. Service authorization request is what we call a SAR, and basically it's a culmination point for a number of factors that we as an MCO and you guys as providers have kind of set as lofty goals to, again, provide the right service at the right time with the right outcome. So we're basically after optimal care for our enrollees, and essentially it's the SAR where that is going to come to fruition. So moving on. When is the SAR due? We have standard timeframes around when the SAR is due and kind of rules around that. Please don't submit the SAR any earlier than 30 days prior to the requested date of implementation of the service. Also, please submit the SAR at least 14 days prior to the date of implementation. This way you can be guaranteed that it will be processed within a timely manner and authorized if everything looks as needed. Those SARs that are submitted outside of those timeframes are not guaranteed to be processed in such a way. We do receive SARs that are not within that time frame, but just know that that kind of puts you, technically puts you at risk that your service would not be authorized within the time frame that you're needing. So, and just to make clear, when I'm speaking of the service authorization requests, pretty much we're talking about within our management information system, Alpha. But some of the information we're covering here is in a general sense too. So I wanted to make sure the technical aspects of this are going to be when you or your colleagues are within the Alpha system inputting the SARs. In addition to that, pre-certification is required. This is an important point because for you to submit a request for authorization with a start date that predates the submission date, so comes before, is technically in violation of our pre-certification policies. So it's very important that you get us the submission for your service authorization request. Again, you want to do so at least 14 days prior, and definitely get it to us prior to the start date that you're requesting. All right, in terms of important tips when you are completing your service authorization request, it's going to be very important and really just smart to double check record keeping as far as making sure that you have the correct population checked on the submission screen, that being mental health, substance abuse, or IDD. Along those same lines, you're going to want to double check eligibility. So if this is a Medicaid recipient, you're going to want to take opportunity to double check that they are listed as Medicaid B. And for IPRS, the same thing. You're going to want to make sure that they are listed as funded for state IPRS dollars. Just because a person may lose their Medicaid B eligibility for whatever reason does not mean that it will automatically fall back to state. Again, you want to make sure that that funding source is on the eligibility file, and you'll be able to access that within Alpha. Make sure that the service and the code are correct. And the service and the code are going to be directly tied to your contract. So again, another probably smart piece of record keeping that you could do is just to double check within the Alpha system that your information as a provider is as it should be, that the codes that you are authorized to render are represented within Alpha, because in terms of entering the SAR, that is the jumping off point. Everything's kind of based on what you are set up for within the system. In addition, you want to make sure that the funding source is correct as you're entering your SAR. So you will, of course, you'll see a series of drop-down boxes when you're entering the SAR, and one of those is for the funding source. So be sure you're selecting the correct one. You will see drop-downs for a given enrollee that carry multiples. So you'll see Medicaid B, state. You may even see a fee-for-service Medicaid, which is only reserved for matters of therapeutic foster care. So be very careful with Medicaid consumers that you're picking Medicaid B unless it's a situation where, I believe for authorizations for therapeutic foster care prior to 3.1, where we're still using the Medicaid FFS, but in large part, you're just going to want to be careful that you're picking Medicaid B. And then along those same lines, Medicaid C would be available for our IDD population, and state or IPRS would be a choice for those with that funding source. Additionally, as you are entering the service authorization request, it's very important that you provide us with contact information. I don't believe there is a dedicated field for you to provide your contact information, but just in any of the free form fields where you're entering justification, or even in a comments section, which is called SAR justification for request. I believe there's a field specifically for comments where both you as provider and we as UM would be able to kind of have a dialogue about the particular authorization request. So I would highly recommend that you include your email address, phone number if you like, because that allows us to kind of get a conversation going in a pretty efficient manner. That's common that there's some administrative piece that needs addressing, and we can easily take care of that rather than trying to track you down through whoever might have your information. We have to kind of search for that. And again, as I said, in a section within the SAR submission screen within Alpha, you will see a tile that's dedicated toward comments. It's called the SAR justification for request area. And that's where we would get any of your comments, and likewise you would get any of ours. Do not assume that any SAR that you've submitted to us is authorized. It's always a good idea to follow up within, within a matter of days. You can follow up to see if there's any conversation that we're having with you again over comments, if we're looking for more documentation or more justification. Again, don't assume that it's been approved. All the service authorization information must reflect what is on the PCP or ISP. Again, this is for enhanced services. You're going to want the information that you're inputting within Alpha to be reflected within the service authorization, within the person-centered plan or the ISP. That pertaining to date ranges, services that you're requesting need to, of course, be reflected on the treatment plan, and so on. And in terms of other required elements within the service authorization request, I want to stress to make sure that the justification you're providing is current. Again, as Dr. Litch said, every request that comes in, we're treating it in a large way as an initial request. So we need to see current justification, not justification for when the service may have begun months ago. That's going to allow us to do our jobs a little more efficiently. And along those same lines, just make sure the documentation that is required for whatever particular service you're requesting, make sure you're submitting that. If a CCA is required to be on file, particularly early on in this stage as we're coming on as the new MCO, and we're not necessarily getting all the records transferred from value options in terms of what authorizations may have already been in place. It's important to make sure we have any documentation. And if that means an extra upload of a CCA, then that's great. Just take that, those extra 2 minutes to do that, and that way we have ample clinical justification. And in addition to that, PCPs, of course, make sure that the documentation within the PCPs and the ISP are accurate. If there are mistakes in the frequency and the units on your authorization request, this slows the process down, needless to say. I ask you to be just very careful and mindful of what you're entering, particularly when you're entering the frequency. There are aspects of that screen which, in my opinion, probably allow too much flexibility to make a mistake. So just be careful as you're entering your units that once you enter the frequency, be it daily, weekly, monthly, or otherwise, that your total units column is giving you the correct field kind of at the end of your submission within Alpha. You want to make sure your total units are correct. We're seeing some mistakes, which is why we bring this up. Frequency is the interval of time in which the units occur. Again, yearly, monthly, weekly, daily, or per auth. Those are going to be the 5 options within a drop-down box that you will see within the Alpha screen for submitting your SAR. And I want to emphasize that the per auth feature is maybe the cleanest one. It's the safest one. Picking any of the other frequencies actually allow the system to kind of do a computation for you. So you will literally see your total units column kind of populate on its own based on what frequency you enter. So again, be careful there. If you're eyeballing it, that's really all you need to do. You'll see if the system is giving you kind of an unusual number for total auths, for total units, I should say. In terms of just some general information, units are either 15-minute intervals of time for periodic services, or they're daily for periods of time that are daily services. Most of your CPT codes that begin with 90, those are going to be session-based, such as 90834 for outpatient psychotherapy session per day. Most of your H codes are going to be unit-based. For example, ACT H0040 is going to be unit-based as opposed to session-based. And I want to emphasize that we have posted our authorization guidelines on the public MeckLINK website. And when you go to that website's homepage, our MeckLINK public website, you would click on providers, and on that very page you will see an Excel file that you can easily download, which will have our authorization guidelines. And again, just to emphasize, in terms of accuracy, this is just an example of what can happen if you're entering your units a little too quickly and don't take notice that maybe the system actually generates a total unit amount that's going to be kind of off the charts. We've seen it happen, so just be mindful of that. At this stage of the game, we're extending some grace along those lines for the month of March, but just be mindful that we're going to require that the requests be accurate, and we'll be in touch with you just to kind of have that conversation if need be. But if everyone's being careful along those lines, we'll be looking good as far as requests go. At this time, I want to turn it over to my colleague, Emily Riggleman. She'll cover some further authorization guidelines.
Good morning. I'm Emily Riggleman, and I'm a care manager, IDD. And this morning, I'll be talking a little bit more about the SARS submission and review process. All providers should use the Alpha Provider Portal to submit SARS. We all got that, right? As long as Alpha's behaving. The review process, routinely we have 14 days to look at a SAR and review it. After that time, it will either be authorized or denied. In the case where we feel like more information is needed for medical necessity, we'll take another 14 days, and then at that time it will either be authorized or denied. And the third type of review is for an expedited SAR, and these are SARs that are submitted for review. They must be related to an issue of health or safety, and determines whether that criteria is met. And if indeed it is that type of a SAR, we will review it within 3 days. If in fact it does not meet that issue of health or safety, it will go back to the 14-day time frame. It's okay to make a mistake. We want to work with you to figure it out. I'm a social worker, so I want to help. The first thing you'd want to do is contact and the way to do that is just to contact the help desk and ask to speak to a care manager, and just specify whether it's IDD or mental health substance abuse. And then we can take a look at it and try to figure out what we need to do together to either fix the one that has been submitted or discontinue that one and start fresh with a new one. What if services or a provider change? What this basically says is if anything changes, a new SAR will need to be submitted to the system and the previous one will have to be discontinued. How do I know when my SAR is authorized? The approved status is visible on the SARs in the provider portal. Check the provider portal to locate and print your authorization letter. And if you are not able to find that or print that, please let us know. Again, call the help desk and we can help you with that. Authorization letters, there will be one letter provided per SAR, and that letter will detail the specific type of service and the amount and length of service. And again, it's important to let know if you cannot download these letters. How long is the authorization period? The authorization guidelines are listed on our website. And again, as John was saying, you can go to the website and they're listed in specifics. Just make sure that the SAR is being completed consistently and accurately. Make sure that what's on your SAR matches the services that are on the ISP, PCP. Provide the required documentation, assessments, make sure that's all submitted.
Good morning. As you know, the state has provided a framework in working with families. Person-centered planning and individual, I should change the slide for, there we go. Person-centered planning and individual support planning are a process whereby persons with disabilities, with the support of families and professionals, direct the planning and allocation of resources to meet their own life vision and goal. ISPs and PCPs are updated annually. The ISPs are updated consistent with the enrollee's birth month. ISPs are submitted 30 days prior to the end of the service year, or if there's a change in services or providers. PCP should be submitted with the SAR annually, or if there is a change in the service type. An example, intensive in-home to therapeutic foster care. Service type, frequency, and duration on a SAR must match the service type, frequency, and duration of the ISP or the person-centered plan PCP. A service authorization request is not complete if a PCP or ISP is required and is not submitted, and vice versa. What if the ISP or PCP changes? All changes and enhanced services will require that an update revision be completed for the PCP or ISP. Once the update is approved, then services will be authorized. Service authorizations will be completed based on the information found on the PCP or ISP. Updates to the PCP and ISP only extend to the end of the annual plan. This is important because a lot of times we'll see they'll submit an update and a revision and they're sort of assuming it's going to extend past when the annual. So whenever the annual is due, that's when it's going to expire. How do I let someone know if I need to make a change in service? For the ISP, alert the care coordinator to the service change so that a revision to the ISP can occur and be submitted to UM. PCP alert the clinical home to the changes so that an update to the PCP can occur, and of course again be submitted to UM. If no PCP or ISP, then simply make a change in the SAR and resubmit to UM, which of course is utilization management. Okay. On the budget pages for innovations, required with request for innovation services, individualized to address service preferences and financial details regarding specific services requested. The budget contains the total cost of the waiver and services authorized. The Innovations Care Coordinator monitors the expenditures per the enrollee. Changes to the service plan must be reflected in the budget and remain within budget limits. Important things to remember. A person-centered plan or ISP is required for all enrollees who are funded through state or Medicaid who receive enhanced benefit services. If emergency approval is required after hours to address a crisis need, the call center can approve based on immediacy and appropriate documentation. The updated plan and SAR should be completed within 24 hours or the next business day of the emergency approval. And to finish our presentation, Dr. Lynch will review the appeals process for MeckLINK.
So an adverse determination is just a long way of saying that we have denied, reduced, suspended, terminated, or denied, reduced, suspended, or terminated a service. Now, an enrollee who receives an adverse determination may disagree with MeckLINK and if we make the decision to deny, reduce, suspend, or terminate a requested service. All adverse determinations are rendered by a licensed psychiatrist or psychologist. care managers do not render adverse determinations, so don't come get them because they didn't do it. They may make the recommendation, but ultimately either myself or a impartial reviewer from a contracted agency makes the decision to deny, reduce, terminate, or suspend a service. Clinical denial is a denial of if a service criteria and medical necessity cannot be determined to support a new authorization request for a service. Now, you ask, well, all requests are new authorization requests for services. So then, all of the adverse determinations will be denials. It will be very rare that we will reduce, suspend, or terminate services. Now, in the event of doing a retrospective review or a focus review, and we determine that the services are really just not meeting the person's needs, and there might be a couple of months left of the service, or if the service is doing more harm than good, we potentially could do a reduction of services at that time or terminate services at that time. I don't see that happening. But we do reserve the ability to be able to do that. A reduction, suspension, or termination of service occurs when services the enrollee is currently receiving may be reduced, suspended, or terminated based on several different factors. Not following clinical guidelines or not continuing to meet medical necessity for the frequency, amount, or duration of a service. So there are two different processes. For non-Medicaid or IPRS state services, a grievance may be filed. A state-funded service is suspended, denied, reduced, or terminated. The enrollee or the provider on the enrollee's behalf, with written permission, files directly with the MeckLINK's appeals coordinator. An enrollee can appeal a denial, reduction, suspension, or termination of services with the Department of Health and Human Services after a review determination is made by MeckLINK. So what happens is that the enrollee for non-Medicaid, they receive the denial issued by an appropriate medical professional. The appeals coordinator gets the information, reviews it, and then if the individual asks, then they can file a request with the state panel at the Department of Health and Human Services. Now, for state an IPRS appeal, for IPRS appeals, you may see Paige Walther's name on the denial letter, and on the appeal letter you may see my name. Now, for the denials, it does not require that for state services that a individual who is a medical professional makes those denials, although we use psychiatrists for those denials through a company called Prest. Paige signs for those denials. For appeals, we also use that same company with an individual who has not been involved in that denial, and then I sign those letters. Now, for Medicaid, it's a little different. Medicaid, individuals who receive Medicaid are entitled to what we call due process, and they're entitled to a state fair hearing. So individuals who disagree with MeckLink's decision must first request a reconsideration review. So that is a local review that is done by a group of impartial individuals who've had no involvement in the decisions made around those services. Reconsideration reviews, I just said that, are decided by healthcare professionals who have appropriate clinical expertise in treating the enrollee's condition or disorder. To request a reconsideration review, did I turn to that slide? Yes. The enrollee or the provider, with the enrollee's written permission, must complete and return the reconsideration review request form by fax, mail, verbally, over the phone, or they can bring the form to MeckLINK. So any way that you want to get us that information, we can go ahead and file for the denial. The request for reconsideration must be made 20 days from the date of notification to request a reconsideration review. MeckLINK will notify the enrollee and provider within 30 days of the decision to either uphold, and uphold means that the impartial reviewer agreed with the decision that MeckLINK made, or overturn, which means that the impartial reviewer decided that MeckLINK was erred in making the decision, and they are granting, are saying that the consumer should get that service. Now, if the decision is overturned, then we will immediately provide that service. So we don't get to think about it and say, well, we think our reviewer was wrong. We would provide that service. A reconsideration can be extended with a possible extension of up to an additional 14 days if the extension is in the best interest of the enrollee, and the enrollee must agree to the extension. So, and I want to step back related to the extension related to reviewing services. So that 14 additional days. The enrollee also has to be notified that we need more time, as well as the provider. So you'll receive a letter or a comment or email saying that we need additional time to review your services as it relates to service authorization requests. And as it relates to an extension of the review time for denials, the enrollee as well as the provider will receive a letter asking for MeckLINK to be allowed to extend the review time for the denial. An enrollee has the right to review any information that has been utilized as part of the reconsideration review. And the enrollee or provider, on behalf of the enrollee, may also submit any additional information that supports the level of services being requested. Now, anytime during the reconsideration process or even up to the Office of Administrative Hearing. If you have information, new information that you think that we need to make to authorize the service, please feel free to submit that. And we are obligated to take that information into consideration. If the enrollee disagrees with the decision, he or she may submit an appeal to North Carolina Office of Administrative Hearings. The form is enclosed with the decision and will start the appeal process. An enrollee may file the appeal with the North Carolina Office of Administrative Hearings within 30 days from the date of the reconsideration review decision. After filing an appeal, the enrollee will be offered the opportunity to have the case mediated. If the enrollee accepts mediation, it must be completed within 25 days of the request. Now, the enrollee can say, you know what, I don't want to mediate, I don't want to talk to these people at the MCO, so let's go on with the hearing. The MCO can't say that. We always have to come to the table to mediate. If the enrollee accepts mediation, it must be completed within 25 days of the request. Mediation is binding. So once the decision is made, that's the decision until the next annual plan or till the next update, whatever's decided in the mediation. Anything that happens in the mediation is like Vegas, stays in the mediation. So we can't take information in the mediation if we decide that, well, we're going to go on to court and use it in the court hearing. If the enrollee declines mediation or the mediation is unsuccessful, the hearing will proceed to OAH. After the hearing, an administrative law judge will make a recommendation, a determination regarding the case. If the enrollee may represent himself or herself in this process or may retain an attorney. Now, in my time in my last job, I have been to OAH hearings, and I will tell you that sometimes the enrollee is a better lawyer than is representing the MCO. So I have seen enrollees do miraculous things in court. You would have thought that they inherited some spirit of some lawyer from past and have done great jobs and have won decisions on their behalf. But, and the enrollee can bring anybody that they want to speak on their behalf. So as the provider, if you want to assist the enrollee and they ask for your request, go to court with them and be as much of a support as possible. So if the enrollee disagrees with the final decision, he or she may retain an attorney and appeal the case to Superior Court. So it leaves the Office of Administrative Hearing and goes on to a Superior Court. Now, I've seen that happen a couple of times. But our thought is if we can resolve it locally, which is the reason for the reconsideration, then that's what we would like to do. Mediation also gives us an opportunity to resolve it locally, and if we can resolve it in mediation, that's what we would like to do. Anytime you go to court, it becomes adversarial, and it's not in the best interest of the consumer, nor is it in the best interest of the provider or anyone else. So again, if you have additional information, remember at any time you can present that information, and it could avoid a lot of hurt feelings later on, I'm just saying. All right, so these are end notes. I wanted to talk about unmanaged visits and pass-throughs. I know that's a burning question. So basic services are considered unmanaged for Medicaid and state for the first 8 adult and 16 children. So in the last hot sheet that went out, we sent you a list of the codes that are unmanaged. We sent you a list of codes that are passed through. We sent you a list of codes that are unmanaged but outside of the 8 and 16. So if you have any questions about that, we can ask in like a few seconds. Unmanaged visits will be renewed annually beginning January 1st of each year. So you're good from 3/1 until December 31st, and then you'll start again on January 1st for next year with your unmanaged visits. As we said before, I believe I said it before last time I was here, if Value Options has already authorized you for unmanaged visits for the year, you're good. You don't have to make that request again. So until your authorization has been exhausted with Value Options, you do not have to make another request for outpatient services. And as soon as you can see it, you'll believe me. All right, psychological testing will be unmanaged for 96101, which is the psych testing that most psychologists do for 5 hours, consistent with what the state has required. 96101 and 96116 will be unmanaged for 4 hours. Those are codes that are normally used by pediatricians for well child visits. And 96118, which is the code for neuropsych testing for 8 hours. Testing will not count against the 8 and 16. So it will be unmanaged, but outside of the 8 and 16. So the only thing that will count against the 8, 6, 16 are outpatient services like psychotherapy, individual and group. MeckLINK will allow annual pass-throughs for services identified in the clinical coverage policy, and those services are SACOT, SAIOP, and mobile crisis. So whatever the clinical coverage policy says, that's what we're allowing the pass-through. I think for mobile crisis, it's 32 hours. For SACOT, I believe it is 60 days, and for SAIOP, I believe it's 30 days. But please check your off guidelines and your clinical coverage policies for the exact time. And please see the February 25th hot sheet for specific codes or MeckLINK authorization guidelines. All right, now, as John said, we have extended grace, which is appropriate since we're in a church. So, as we have already discussed, for the locus cal locus, please begin entering those scores on a consistent basis through March 31st. So after that time, again, we can't deny a service or administratively to deny a service because your locus or cal locus is there, but we'll be a little angry, and we may send you an angry note. MeckLINK Service Management will allow providers to seek retro authorization until March 15th. It's actually going to be March 16 at midnight for services not previously requested in January due to system errors. This is the CPT codes. So the old CPT codes were discontinued December 31st, 2012. They were not entered into our system until around January or February. So that left a lot of people not being able to enter those requests. So you have up till, when's the 16th? Saturday. You have up to Saturday at midnight to enter those codes to claim against those services. And then finally, MeckLINK will allow a grace period of 30 days beginning March 1st for service authorization requests submitted through Alpha that expire March 1st or soon after. So if you have submitted a request for authorization, let's say your request ended March 1st, March 2nd, March 3rd, and you've not already received your authorization, then we will honor the authorization back to that date if we have not already approved or reviewed that service, as long as it's been entered during that time span. Traditionally, as you know, we don't backdate, but again, this is a new process for everyone. All right, let the onslaught begin. Questions? Ooh. Could you also speak to LIPs who do not use a PCP or an ISP? All right. So, this is interesting because we did have a conversation about this yesterday. And in the hot sheet, today or tomorrow, whenever it goes out, there is a listing of a hierarchy of individuals who should be responsible for the person-centered plan and the clinical home. If a consumer is just in outpatient services, the requirement for that service is that you have a service order and that you have a treatment plan in your record. It does not require that a person have a person-centered plan. Now, if the consumer is, for instance, in a residential treatment facility, and they're also receiving, there's a lot of questions, huh? They're also receiving outpatient services, then the residential treatment provider, who is the keeper of the PCP, in that situation would have to add individual services to outpatient services to the PCP and be responsible for submitting that so that you can bill your SAR. It adds to continuity of care amongst providers, and it allows for one plan, one person. Okay. I'm just going to be able to have time enough to go through a few of these, but we'll do the best we can. I heard yesterday at the NPN, what's the NPN? I don't know what that is. That there is a new innovations waiver to come out April 1st. Can you elaborate?
The current innovations waiver runs on a 5-year period, which is coming to an end, and so there should be a new waiver starting April 1st for that population. I'm sure it will look very similar to what we already have in place, but that waiver was a 5-year waiver, which, as I said, is coming to an end. I haven't seen a copy of it yet, but I anticipate the state will have that for us hopefully soon.
Okay. How do we identify a point person in your system for our agency regarding authorization issues, clinical issues? Hey, Julie, what's up? Okay. How do we notify MCO of agency changes? In terms of clinical questions, please call 704-336-6404. Ask to speak to a care manager. Normally, the person who authorized the service initially is going to be the care manager who is going to be concurrently reviewing the next service. So for that individual, so that person's information is on the SAR. But if the service has not been authorized yet, please call our 6404 number, I'm sorry, and ask to speak to a care manager, and anyone can help you with any question that you have. Please indicate innovations or IDD versus mental health substance abuse. Okay. How do you determine if a service is experimental? Is there anything that has already been deemed evidence-based? Well, there are certain services that are standard, and we do have, what do you call them, Dr. Peterson? Best practice guidelines that are posted on our website. If you have evidence to support, peer-reviewed evidence to support the efficacy of a particular service, please provide it to us, and our credentialing and qualifying committee will review that information and then make a determination about whether or not it's a service that can be provided within our network. Now, again, we're not the be-all, know-all on everything, so we do things by committee. So if you have some questions about a service and whether it is evidence-based, please give us a call. We can review and then provide you some feedback. If we provide outpatient and go beyond the unmanaged sessions, do we switch from our treatment plan to the PCP? No. You still stick with your treatment plan. You just submit a SAR for any additional services beyond the unmanaged visits. Okay. Okay, we'll get back to you on that one.
Dr. Lynch,
Yeah.
I just have a question to add on to that one for the unmanaged. The after 16, would it be helpful to upload the CCA as well with that one? I mean, what I'm hearing you say, only have to do the SARS and that's it. But would it be helpful to upload the other components?
I'm not understanding what you're saying.
Okay, so for the outpatient,
Yeah.
up to 16 unauthorized, as we're preparing, we have to go over that.
Right.
Do we need to upload the CCA and the treatment plan we're currently using plus the service order?
No, we don't need to see the treatment plan or the service order, though you need to have it in your chart in the event of review. All you would need to do is present the SAR and then provide some justification. Now, if you want to upload that information, you certainly can, but you don't have to. All right. So, in related to innovations waiver, people who use IDD and receive other services, does each agency do a SNAP? No, the care coordinator would do the SNAP. Right? Yes. Will we get authorization letters from MeckLINK for the added uploads from value options? I do not believe so. Once you can see them, you'll see administrative something in the system. Can anyone answer that question? I don't want to say no. Okay. Can providers fax supporting documents if no electronic copy is available? Yes, you can fax. There is a fax number. I don't know it right offhand. That would be my fax number, so I should know it, huh? Why are all discharges from Broughton going to ACT? That's a good question. Will referrals be given to ACT that do not have waiting lists? What is needed to get additional for ACT consumers that need more than 4 visits per month? Why, when authorized, do they get 8 visits for 2 months on the last day? And so this might answer a lot of questions. We follow the clinical coverage policies that are set forth by the state. In the event that there's no information on the clinical coverage policy that would direct utilization management, we have been following what we have been authorizing under state services. If there is clinical justification for services beyond the clinical coverage policies, please provide that with any additional information, and then we can, at that time, make a determination as to whether or not the consumer would benefit for further additional services. Okay, that might answer about 10 of these questions. Okay, so I'm told that we have to leave at 11 o'clock, and so we probably only have time for one other question. What we will do is we'll go through all of these questions, and we will post them on the web, not today or tomorrow, but we will post them very soon with frequently answered questions. So one more. What is the update on VO authorizations in the MCO system? What date will it be loaded? Thank you. As said, we hope the target date will be tomorrow. That's our target date, is Thursday. Okay, thank you all.